Thank you everyone for joining us today. Good morning or afternoon, depending on where you're located. Okay. So today we're going to talk more about grade and site-specific data items. If you have questions throughout the presentation, feel free to add them in the chat. Heather and Lauren will be working behind the scenes, reviewing those. And if we have time at the end, I will answer some questions. However, I do have a lot to go through, so I'm not sure we'll have time. But as always, we will have a Q&A document with all of the questions and answers, and we'll send that out in about a week to everyone. So let's go ahead and get started. So here are the objectives. We're going to go over the grade and SSDI general rules as well as some site-specific rules. So if you want to go ahead and open up your grade manual and your SSDI manual on your computer, then you can help follow along. I'm going to have questions to reinforce learning and check our understanding of these concepts and rules. So let's get started with our first question. So question number 1, a patient presents with an abnormal screening mammogram. They undergo a biopsy and the results are atypical ductal hyperplasia. So the surgeon does want to go ahead and remove this tissue, and afterwards the path results show high-grade DCIS. So how are we going to code this clinical and pathological grade in this case? So you should see a poll on your screen. Go ahead and choose an answer. Okay, we're starting off kind of easy. Y'all are doing great. So the biopsy was ADH, and then the excision was DCIS, high grade. Okay, we're going to give a few more seconds. Okay, so %74% got it right. Let's look at the answer. So we're going to go to first the general rules for coding grade, and we're going to find note 8. So note 8 says that we're going to code 9 in the pathological grade when the clinical workup is not done. For example, cancer is an incidental finding during surgery. So that's exactly what happened in our scenario. Cancer was found incidentally during a surgery for the ADH. So we're going to code clinical grade 9. And then this patient does qualify for pathological grade since she underwent the resection. So here's a snip of that breast grading table. So we can code H for high grade per the path report. So note that we can only use L, M, and H for in situ tumors, and you'll see that here on that table. So the answer was D, clinical grade 9, pathological grade H. Great job. Okay, let's look at question 2. So patient undergoes a colonoscopy and is found to have a rectosigmoid mass. The biopsy shows invasive, moderately differentiated adenocarcinoma. And then the imaging workup shows that the patient has liver masses. Biopsy was performed on those liver masses and was resulting in mets. So it was poorly differentiated adenocarcinoma consistent with colon mets. So the surgeon decides no resection. We're going to start the patient on palliative systemic treatment. So my question is, what are we going to do for pathological grade here? So pathological grade. Okay, we're slowing down, a few more seconds. We're pretty split on this one. Okay, I'm going to end it and close it. Okay, so let's look at this one a little closer. So the biopsy of the colon was moderately differentiated. The liver met was poorly differentiated. So again, we're going to go to that same note for pathological grade, note 6 in the general rules. It tells us we can use the grade from clinical workup when there's no surgical resection, but there's positive microscopic confirmation of distant mets during the clinical time frame. So that's what we have here. We have no surgical resection, and we have positive mets in the liver. So we are going to use the biopsy of the colon, which was moderately differentiated, as our grade in both clinical and pathological grade fields. If you go to the colon grading table, you'll see that moderately differentiated is grade 2. So we're going to do grade 2. Okay, question 3. So now we have a colonoscopy reveals a mass in the ascending colon. The biopsy shows moderately differentiated adenocarcinoma. The patient undergoes a hemicolectomy, and it shows well-differentiated invasive carcinoma. So how are we going to code pathological grade this time? Okay, this one we're overwhelmingly having the same idea. A few more seconds. We'll close this one quickly. Okay, so 82% said grade 2, which is correct. So we will go to that same note 6, and it tells us we can use clinical grade from the primary tumor as long as the behavior is the same. So both the biopsy and the resection both had invasive carcinoma, so the behavior is the same. Then clinical grade is higher. We're going to use the clinical grade in the pathological grade field as well. So this one will be clinical grade 2 and pathological grade 2. Again, here's that colon grading table that shows moderately differentiated is grade 2. Okay, question 4. Now let's look at a breast case. So this patient has a mass and undergoes a biopsy. The path results show invasive ductal carcinoma grade 3. She undergoes neoadjuvant chemo followed by a lumpectomy. Now the path results on the lumpectomy show that there was residual carcinoma, invasive ductal carcinoma, and it's grade 2. So how would you code the post-therapy pathological grade? So can we use the biopsy grade 3 or the post-therapy grade 2? Okay, a few more seconds. Okay, we are pretty split on grade 2 or 3, but most of you have grade 2. So let's look at this one. So I tried to trick you on this one. So the biopsy was grade 3, after resection grade 2. So if you look at the general rules for post-therapy pathological grade, it says to note 3 to assign the highest grade from the resected primary tumor after the completion of neoadjuvant therapy. So we cannot use the grade from the biopsy because that was not after neoadjuvant treatment. So we will look at the breast grade table and we will grade 2. Okay, next question. So the patient presents with a right lateral tongue lesion. An excisional biopsy is performed and it results in ulcerated, moderately differentiated squamous cell carcinoma. The patient underwent a partial glossectomy and had a little bit of residual focal low-grade dysplasia, but no evidence of carcinoma. So how should we code the pathological grade in this case? So pathological grade. Okay, we'll do a few more seconds. Okay, so we are mostly split between 2 and 9. Let's look at the answer. So this one we're going to go to note 6, and it says that we can use the grade from the clinical workup. And then under surgical resection, if surgical resection is done and there's no grade documented, or if surgical resection is done and there's no residual cancer. So that's the situation in our case. The patient had resection, so qualifies for pathological stage. We wouldn't use 9. We can use the clinical grade in the pathological grade field. Good job. Okay, number 6. This patient presents with an abnormal screening mammogram, undergoes a biopsy that results in invasive ductal carcinoma grade 1. Patient undergoes a lumpectomy and there's no residual invasive carcinoma. However, there is some high-grade DCIS present. So how would you do your clinical and pathological grade in this one? So the biopsy was invasive, and then after resection, all we have left is DCIS. Okay, a few more seconds. Okay, the majority said C, so let's look at the answer. So C is correct. So if you go to the general rules, again, we have note 9, use the grade from clinical workup. If the tumor behavior for clinical is invasive and the tumor behavior for pathological is in situ. So we're going to ignore the high grade and we're going to code the grade 1 from the invasive from the biopsy in both the clinical and the pathological grade fields. Okay, next question. Now we have a 66-year-old male with a mass in the pancreas. He underwent a biopsy, which resulted in moderately differentiated adenocarcinoma. He goes on to have a Whipple, which results in high-grade adenocarcinoma. So what are we going to do here for clinical and pathological grade when we have moderately differentiated on the biopsy and then high grade on the resection? Okay, we have fewer people voting on this one. This one must be a hard one. Okay, we'll give you a little bit more time. Okay, we are pretty split between A and B. So let's look at this one. So if we go to the general rules, under note 2, if there's a preferred grading system for your schema, if the clinical grade uses the preferred system, but the pathological grade does not use the preferred system, we're instructed to not use that clinical grade in the pathological field, and we're supposed to assign a grade 9 pathologically. Okay, so in this case, we have a grade, a preferred grading system you'll see is 1, 2, and 3. So the biopsy being moderately differentiated falls in line with grade 2. However, the high grade that was found at resection is not preferred. We cannot use that high grade. So we can code clinical to grade 2 because that falls on our table under moderately differentiated. But for the pathological grade, we're going to have to go with grade 9. That's a tricky one for sure. Okay, next one. So question 8. The patient presents with a headache and nausea and vomiting, and the family members note that the patient has also had some altered mental status lately. They perform an MRI, which shows a large heterogeneous 6.7 centimeter enhancement in the right temporal and occipital lobes with extension into the hippocampus, most consistent with a glioblastoma multiforme. So the tumor was deemed unresectable. No biopsy was performed because of the dangerous location. So how are we going to code the clinical grade when we don't have one? All we have is imaging, no biopsy. Let's launch the poll. Okay, just a few more seconds. Okay, it looks like grade 4 and grade 9 have the most votes. So most consistent with glioblastoma multiforme, we can use that as the diagnosis. If you look at note 6, there are some particular sites in the CNS, particularly, where we are allowed to assign a grade if one's not given. So code from the WHO grade table in AJCC 72.2, and here are just a few of the entries that are from that table. And if you were to look at it, you would see glioblastoma is grade 4. So if you're not given a grade, you are allowed to use this table to have a grade. So clinical grade will be grade 4. Also note in that top box at the very bottom for benign tumors that are behavior 0, you can say a code 1 for clinical grade automatically for all histologies. So you shouldn't have a benign brain with a clinical grade 9. They should all be clinical grade 1. Okay, now we have a patient with postmenopausal bleeding. They find a uterine mass and the biopsy shows low-grade endometrioid carcinoma of the uterus. So how are we going to code the clinical grade for low-grade endometrial carcinoma? Oh, I can tell some people are not using the manual. So for this one, you're going to want to go to the corpus uteri instructions. See if I can help some people out here. Okay, just a few more seconds because I have a lot more questions to go through. Okay, so we're pretty split between 2 and 9. So let's look at this one a little closer. So we actually have instructions for corpus uteri to code low grade as grade 2. So endometrial carcinomas only if you're reported as low grade, code 2, and if they're reported as high grade, we can code 3. So good job to you guys that got that one right. Okay, the next one. So patient presents with gross hematuria, cystoscopy, performed, and the bladder mouse is found. Patient further undergoes a TURB, which reveals invasive urothelial carcinoma grade 1. So how are we going to do clinical and pathological for this one? Okay, so a TURB, invasive urothelial grade 1. Okay, a few more seconds. And I apologize, we're going so fast, but I have so many more to share. Okay, so looks like we're kind of going between those two. Okay, so for this one, we're going to look at the bladder. And the bladder specific instructions tell us that for bladder, a TURB qualifies for clinical grade only. So clinical grade is going to be the only thing that we can assign, and our path grade will be 9. Now, we have a urothelial carcinoma, and note 4 tells us that urothelial carcinomas will use L, H, and 9. So we can only use L and H for these, and we were given a 1. We cannot use that. So we're going to have to code this one a 9 per note 4. If only grade 1 through 3 are documented, code 9. So I know as registrars, we don't like to code 9, but we have specific instructions on this one to code 9. Okay, question 11. Patient presents with self-palpated left breast lump. Biopsy was performed and results in DCIS grade 1 out of 3. So what would your clinical grade be for this one 1 out of 3. Okay, a few more seconds. Okay, it looks like we're looking at grade L. Great job. So we have a note for breast specific instructions under note 7 for in situ tumors. Documenting for these sometimes will be given as 1 out of 3, 2 out of 3, 3 out of 3, but note that this notation is talking about nuclear grade and not Nottingham grade. So invasive breast cancers are documented in Nottingham grade 1, 2, and 3. These are not the same. So if a pathologist uses that grade 1, 2, or 3, they're really talking about the L, M, and H for in situ tumors. So do not use 1, 2, or 3 for in situ tumors for these instructions. So we will take that grade 1, DCIS, and we will say grade L. Okay, so here are some grade reminders. So we're finished with the grade questions. Code grade from the primary tumor only. So if you don't have a primary tumor biopsy and all you have is a grade from, say, a liver met or somewhere else, you cannot use it. Now, there is an exception for breast that I stuck there in that box. Just look at that when you have time. Grade, if it's reported as a range, you're going to code the higher grade. So if it says grade 2 to 3, you're going to code 3. Code the grade from the invasive when you have both invasive and in situ. So even if the invasive is lower or unknown, you're still going to code from the invasive, not the in situ. We do have a priority order for our grade. So synoptic, followed by path report final diagnosis, followed by physician statement. I know sometimes registrars want to take the physician statement first, but that's last on the list. We need to follow the order that's given in our instructions. You will also take the grade from a consult review over the original biopsy. So if a patient has a biopsy and then comes to your facility and they reread it, or they send it off to another facility like the Mayo Clinic or MD Anderson, somewhere like that, that consult review will take priority if it's lower or higher, or if it's different. Consult review takes priority. If you have multiple tumors that are abstracted as a single primary and they all have different grades, you're going to code the highest. For the path grade, we are allowed to code the highest from any specimen. So it could be the biopsy or the resection specimen, whichever one is highest, we're going to capture in the path grade. And then also remember, there are some surgical procedures that only qualify for clinical grade. For example, TURP in the prostate, TURB in the bladder, a shave, a punch, or incisional biopsy of the skin. So those are all coded as surgeries, but we use the results in the clinical grade field only. Okay, let's move on to some SSDI questions. So now we're going to move over to the SSDI manual if you have that open. So we have a patient that presents with hepatocellular carcinoma diagnosed on imaging, which is most frequently how we see it diagnosed. And the patient has an AFP of greater than 456. How would you capture that in the SSDI field for AFP? Greater than 456. Okay, we'll give you a few more seconds. Okay, here are the results. So let's take a look. So we have general instructions for the SSDI manual, and it tells us when you're recording less than, greater than, or at least. So it tells us if it's more than, which is this scenario, we're going to go one higher. Okay, and it depends on the actual SSDI if you're going to go one higher or 0.1. So it's going to be 1 unit higher. So because AFP is documented with a point to the, it's to the highest tenth, we're going to do 456.1 because that's one value higher than 456. So another example would be if we had tumor deposits, if you had more than 10, then you would code 11 because tumor deposits for colon only have the 2 digits without the decimal point. Okay, so how about this one? The patient has a breast biopsy, and how are we going to code the key 67? So it's reported as 5 to 10%. Then the patient goes on to have a lumpectomy and there's no additional testing performed, which is common. So can we use the Ki67 from the biopsy is the first question. And then if so, how do we code 5 to 10%? Okay, it's kind of slowing down. A few more seconds. Okay, here are the results. Okay, let's look at this one. So the general rule for ranges tells us when a result is documented in a range, code the next highest number based on the lower value. So this again is going to be dependent on how the SSDI is collected, whether it has a decimal point or not. So 5 to 10, the lower number is 5, and then Ki67 is documented with that decimal point. So we're going to go one value higher would be 5.1. Okay, great job. Okay, the next one. So this patient has colon cancer and undergoes a hemicolectomy. The results are adenocarcinoma, and there's no mention on that path report of KRAS. The patient did, however, undergo Guardant 360 testing, and the results scanned in the chart are here on the screen. So KRAS G13D is mentioned as an alteration. So how would you code this in the SSDI for KRAS? Okay, we're gonna end this one. The majority say we're gonna say abnormal in codon 12, 13, and or 61. I'm so glad I put this one in here. So Garden 360 is a liquid biopsy. So per NCI, a liquid biopsy is a lab test performed on blood, urine, or other bodily fluid. So we are only allowed to use tissue for this particular SSDI. So there are two types of SSDIs. We'll look at the next screen, but this one for KRAS is based on tissue. And it tells us that if no microscopic evaluation mentions this SSDI, then we're going to code unknown. So we did have microscopic examination of tissue for the biopsy, but there was no KRAS mentioned. So this patient went on to have that liquid biopsy, and it was positive for the KRAS mutation, but we cannot use that in this SSDI. So if you'll notice in the manual, there's two sections. So there's rules for recording tests based on solid tissue, and then there's rules for recording lab values. So it's very important that you make sure you understand the rules for both of those and then know which value you're looking for. So for example, some that require tissue are your breast ERPR, your colon, BRAF, NRAS, KRAS, your prostate, and your lung. On the other hand, there are some that do use lab values. So the PSA, the CEA, the LDH for melanoma, those are some examples where we can use blood, urine, ascites, spinal fluid, those kind of things. So make sure you check that out in the SSDI manual to make sure that you're capturing it correctly. Okay, let's move right along. The next patient presents to the ED with abdominal pain. Imaging shows a mass in the descending colon, suspicious for malignancy. So they go ahead and draw a CEA. The patient undergoes a colonoscopy, which was positive for adenocarcinoma. And then they draw another CEA, and the patient undergoes a left hemicolectomy. So how are we going to code the CEA in this case when we have so many of them? They launch the poll. So the patient was diagnosed on imaging on 4/4. And then the colectomy was 4/21. Okay, we're going to go ahead and close this one. I think a majority of you are on the right path. So whenever you're given more than one value, the general rules tell us to record the highest. So in this case, the highest was the 21.4. Okay, let's look at a prostate case. This patient was referred to urology for an elevated PSA of 8.23, and then the urologist goes ahead and repeats the PSA, and it was down a little bit, 7.6, undergoes a biopsy, which was positive for cancer. So how are we going to code the PSA when we have two of them in this case? Okay, I think we're Slowing down on this one, it looks like we are torn between two of them, but the majority say 7.6, which is correct. So the general rule does tell us to code the highest when there's more than one. However, we need to make sure that we go to the prostate rules. The prostate rules give us specific instructions to record the last pre-diagnosis PSA prior to the biopsy. So even though the first PSA was higher, it was 8.23, we need to code the 7.61 because it was the last one before diagnosis. Also remember your lab values need to be within 3 months, which both of these fell under 3 months. So that's not in play here, but it's worth mentioning. Okay, the next one. So now the patient has an elevated PSA, undergoes a biopsy. The path results show Gleason score 4+4. Then the patient goes on to have a radical prostatectomy with Gleason score 3+4. So how are you going to code the Gleason score pathological in this case? So the biopsy is 4+4, and then the resection is 3+4. Okay, we're going to go ahead and end this one. And then let's look at it. So I did try to trick you on this one. So remember, unlike grade, we're talking about the pathological Gleason score. So this actual field is looking for the pathological Gleason score, and we're only going to use the score from the radical prostatectomy, which was 7. Okay, next one. So patient is found to have a mass in the hepatic flexure on colonoscopy, and the path results show adenocarcinoma, no perineural invasion present, no lymphovascular invasion present. So the patient underwent surgery, hemicolectomy, and now the path results show adenocarcinoma and lymphovascular invasion is present, but no mention of perineural invasion on this path report. So how are we going to code the perineural invasion when there was none on the biopsy and no mention on the path report? Okay, a few more seconds. Okay, here are the results. And let's look at it. So we have specific instructions for coding perineural invasion for colon. And it tells us under note 3 that the information on the presence of perineural invasion must come from the biopsy or resection, but the absence of perineural invasion can only be taken from the resection. So even though we have a negative perineural invasion on the biopsy, we cannot use that. We have to have it from the surgical resection, which there was no mention in this case, so we're going to have to code 9. next one. So patient underwent a colon resection. The path results show adenocarcinoma in a tubulovillous polyp. Margins are negative. The closest one is 2.4 centimeters. How would you code the CRM if this is all the information that you have? Okay, we're slowing down a little bit. So here are the results. And we're going to look at the colon-specific instructions for this one. So we are going to code in centimeters, first of all. Also, there are some synonyms for CRM, and I've included them here for you. So mesenteric is one of the synonyms. So we can use the 2.4 centimeters for the mesenteric. And I apologize, this one's recorded in millimeters. So we need to take the 2.4 centimeters, convert it to millimeters by multiplying it by 10. That gives us 24 millimeters. So your answer will be 24.0. So just remember to look for these synonyms. Sometimes it's in the final diagnosis. Sometimes it's not there, and you can even look in the gross description where they're describing the tumor and the way it looks. They might show you the margin down there, and you're able to code it. So read the entire path report and look for these synonyms. Okay, the next question. Patient is undergoing a screening colonoscopy and found to have a pedunculated polyp in the descending colon. A polypectomy was performed with a snare. The results were adenocarcinoma. A CEA was obtained, and then no further treatment was recommended. It was determined that that was definitive. So how would you code the pretreatment CEA value here? This question looks like it was too easy. You guys are all getting this one. Great job. I'm going to go ahead and end this one since we're running short on time. Here are the results. Okay, so for this one, the CEA was obtained after the polypectomy, and because no further treatment was planned, the surgeon decided that that was definitive treatment, so we can't use that CEA. If the patient had gone on to have a more definitive surgery, we could use that, but we do have a note on the colon section, note 2, that says record pre-treatment results only, and it has to be prior to the polypectomy. So good job on that one. Okay, the next one, patient presents with an 8 millimeter left upper arm lesion. A biopsy is performed, and the path results show invasive malignant melanoma with a Breslow's depth of at least 3 millimeters. How would you code at least 3 millimeters? Okay, we'll do a few more seconds. Yeah, I can tell some people are using their manuals. It was pretty split for a while. Now we're getting to one is sticking out there. Okay, so close the poll. So let's look at this one. So when they tell us at least 3 millimeters, our general rule for at least is to go one higher. But you need to make sure that you look at the site-specific rule for melanoma. This tells you that we have A codes, so make sure that you use the A code if they tell you at least. So in this case, at least 3 millimeters will be coded to A3.0. Great job. Okay, the next one, patient presents for a full body skin exam and is found to have an 8 millimeter ulcerated lesion on the lower left leg. A shaved biopsy is performed and the results in superficial spreading melanoma with no ulceration. So how do we code the ulceration in this case? The physician noted that it was ulcerated, but then the path report says it's not ulcerated. So let's go ahead and launch that poll. Okay, we're going to end this one. Great job on this one. So we have specific instructions for melanoma ulceration. Under Note 2, ulceration can only be confirmed by microscopic examination. Do not use findings from the physical exam. So the ulceration that we're looking for in this field is not the same as the ulceration that the physician is seeing during the physical exam. So it's important to only look at the path report. Our path report said no ulceration, so we're going to code 0 for this one. Okay, thanks for hanging in there. We have a few more, guys. So this patient presents with a breast mass and a suspicious axillary lymph node, undergoes a biopsy of both the mass and the lymph node. The left breast is IDC grade 3. The lymph node is metastatic carcinoma. Patient undergoes neoadjuvant chemo, a lumpectomy, and a sentinel lymph node biopsy. The results are a minute focus of residual invasive ductal carcinoma grade 3. 3 sentinel lymph nodes were examined and they were all negative. So how would you code the SSDI lymph node positive axillary levels 1 through 2 in this one? So we had a positive FNA during the clinical workup, neoadjuvant chemo, and then sentinel lymph node biopsy was negative. Okay, we're going to do a few more seconds. Okay, great job. So this one, I know it's hard. You want to say 1 because there was 1 positive biopsy at the beginning, or maybe 0 because there were none on the path report. But we do have specific instructions for breast, and it tells us to code X6 if there was only a positive aspiration of level 1 or 2 lymph nodes, because this one is looking for the lymph nodes removed. Okay, now we have a patient with a breast mass and suspicious left axillary lymph nodes. They biopsied both of them. The left breast mass was we're looking at PR here. So the PR was positive 70 to 80%, and then the lymph node was greater than 90% positive. So how can we code the PR percent positive in this case? Which one do we use? Okay, again, I apologize. We're going to give you a few more seconds because we're running out of time. Okay, here are the results. Majority want to use that R80. So this one's actually going to be XX9. So the first question I was looking for was, do we use the breast mass or the lymph node? So we do need to use the breast mass, which was 70 to 80%. So we have general rule that tells us to code, when you're given a range, you would code the next highest. So you would code the next highest from that range of 70 to 80 from 70. However, we have breast specific rules. So when you have a primary site that has specific rules, that always takes priority over the general rules. So we do have this rule that if the range is greater than 10, we have to code unknown. And 70 to 80 is actually 11. So we need to code unknown, XX9. I know that one's confusing. That one I see on QC, so keep an eye on those rules. Okay, last question. So patient presents with a left testicular mass and has an AFP drawn, undergoes a radical orchiectomy, and then has 2 more AFPs drawn before beginning etoposide and cisplatin. So how would you code the post-orchiectomy value? Okay, we'll do a few more seconds. I know it's fast. Okay, so here are the results. Let's look at this one. So we do have specific instructions for testes that tells us that if the initial post-orchiectomy AFP remains high, review subsequent tests and record the lowest prior to neoadjuvant treatment. So right after surgery, it was still high, and then it went down to 16.3 before starting treatment. So we're going to code that 16.3 based on that rule. So here are just some reminders for coding SSDI. I know we are out of time, so I'm not going to take too much time to go over these. That is everything. You should have these in your slides for reference later.